Man 2 test, and Sarah's perfect example here. So she got a TB skin test. It's all red. Yesterday. It's all red around it. It's kind of in a weird spot, by the way. It's normally down here. But the first thing I did was what? I touched it. If they do this and they go, yep, you're good, they did not read your TB skin test. They didn't. And if you're reading a skin test, you cannot read it just doing that. You have to feel. It has nothing to do with the redness at all. It has only to do with it being raised. Now, obviously, not everybody got the memo, but this is how it's been from the beginning of time. They don't always do it right. You have to feel it. And you're feeling for that induration, that raised area. So unfortunately, you do have to know this number, 10 millimeters. And again, it's not the redness. It's that swollen, raised area that we're looking for. And again, it does not mean you have TB. It means you have made antibodies to TB, so you have been exposed. And then we got to do this other thing. This is critically important. If you're positive one time, you're positive forever and ever. That means you don't need another TB skin test again. And when they say you got to have one, you say, well, I've been positive before, and what they're going to do is a chest x-ray. And it used to be that you had to have your TB skin test every year. If you were positive, you had to have a chest x-ray every year. The guidelines have changed to about every 5 years, but people are still behind. So probably even DSN makes you get a chest x-ray every year. And that's all right. That's policy, and they can do that. But that's how it works. If you're tested annually, once you're positive it doesn't matter for the reason, if you're positive ever, you're positive forever, and you never need another one. I mentioned this yesterday. If you're immune compromised, like you have HIV or any other immune suppressive disease, you're not going to have as strong as a response to tests like this because you just don't have a strong immune system. So even a 5, half, you don't have to know that number. Just know less. I don't touch on that. You might see that in HESI and those kind of books. But less than half what we would consider a healthy person positive, we would consider you positive. And if you think about the reason, it makes sense. They just don't have a strong immune response. Now, the BCG vaccine. Please, please hear what I'm saying. We do not give BCG in the United States. Do not assume that if someone has a positive skin test, that they have got BCG vaccine. The only people that have BCG vaccine are people who grew up in another country. So if your question in the STEM said this patient grew up in Africa and now is in the United States and has a positive skin test, well, absolutely you would ask them, did you get BCG vaccine as a kid? Because in countries where TB is epidemic, which is not the United States, they do give BCG vaccine. And they give it to children, and once they've had it, they will have a positive skin test. Those people know, and they will say, my mom told me I should never take the skin test. It's because they've got the vaccine. Is that just the vaccine that gives you the antibodies for it? Yeah, I mean, it's a vaccine like everything else. It stimulates your body to create antibodies to it. So the question then becomes, if we do it in other countries, why don't we do it here? Why don't we just give the vaccine to everybody? Yeah, it's not epidemic here, and if we gave it to everybody, we can't do TB skin tests anymore. So now, how are we going to screen people for TB? It becomes more expensive. You either have radiation exposure, or you got to do a blood test, and really the blood tests have only been around for a few years, so it doesn't make sense for us to do it in the United States. So please do not assume if somebody has a positive TB skin test, on an exam, that they got BCG. It's just highly unlikely that's the problem. The more likely thing is they've been exposed to TB and they have antibodies in the United States. All right, now these interferon release assays. This is a new blood test in the last couple of years. In fact, I'd never even heard of it till last year. It was not in our books until this new edition. So I'm adding it on. What we're finding in the metro area, we've got several hospitals that are doing the blood test instead of the skin test. The thing about the blood test is called quantiferin or by BCG, nor is it affected by people knowing how to read the skin test correctly. Instead, it's a blood test that actually mixes antigens, antibodies, or whatever it does, I don't know, mixes some protein and it looks for a response. So it actually does tell us. It will not tell you if you have active TB or latent, though. So you still have to do the same steps if you have a positive to this as to the other. And there's no recommendations on how often to have it. So some hospitals, you're only doing it once, you're never doing it again, but the CDC does not have those kinds of recommendations about yearly or every 5 years or whenever. So it's vague. Just know it is a blood test, it's not a skin test. So we do the TB skin test, it comes up positive. We know they don't necessarily have active TB. The next thing we'll do is a chest x-ray. If they already have had a positive any time in their lifetime, they will only do the chest x-ray. Remember, you can't diagnose it with the chest x-ray. You've got to move on. So if the chest x-ray looks bad for any reason, doesn't look normal, then you go to a sputum smear for the AFB. And they do 3 on separate days. Watch it. That's everything. Alright, treatment. So, first thing is isolation. Our sexy nurse here. The duct mask, that's that fit tested mask. Usually, if you work in healthcare, you have to be fit tested. It's kind of cool, the testing. You remember doing it? They put the mask on you, and it's really fit by height and weight. That's how it's fit. But when they take the one that works for your height and weight, put it on you, and then they run smells, these scents underneath your nose, and see if you can smell them or not, so they can tell if you're going to be protected. And then if that doesn't fit, they got to figure out what to do. But that's fit tested mask. So it's not our typical mask. It's more specific. They also need to be in airborne isolation, obviously, with these fit tested masks. This right here, this is DOT, directly observed therapy. If you have a choice of what's best for TB, it is DOT. DOT means the patient physically goes to a location every day to get their medications. And so oftentimes they're here in downtown areas. They're little TB centers. It's not the health department, it's a center. It's a little TB center, and it's usually down by homeless areas, places where there's a lot of poverty, because that's our higher risk for TB. The patient comes in, they give them their med, they send them on their way. They usually have some incentives, like there'll be a food pantry there, a clothes closet, maybe a needle exchange program for addicts, that kind of stuff. The whole idea is this. The reason we get multi-drug resistant strains are because people don't take these meds. They have side effects. You got to take them every day for 9 months. People won't take them, and then they get drug resistant, and then we don't have any treatment for them. So the best treatment is directly observed therapy. Now, you guys, if you get exposed to TB and you have latent TB and you got to take the meds, they're not going to make you go to a center, because they can tell you how important it is to take it, and they can feel relatively confident you will follow their advice. But for a lot of the population that gets TB, they're not going to take it. So we want them to do directly observed therapy. So that is preferred over anything. They are going to take multiple drugs. We're going to cover those on the next slide. TB skin testing. Do we need to do that when you have active TB? No, that helps us diagnose you. And once you got active TB, is there any point in skin testing you again? No, because you're going to forever be positive. So who are we going to TB skin test? Close contacts. Remember, it's not that easy to catch, so close contacts. Family members. If, again, somebody in this classroom got TB, we'd be testing people in this classroom, but it's usually family members. This, strict hand washing. That's one of the best techniques for them, is good hand washing. And this is at home. Are we going to have them on isolation precautions at home? And they're not going to be in the hospital from TB. Usually they're in for something else, and we discover TB, or they have it anyway, and they're here the only one you take. Rifampin, ethambutol, and there's a fourth drug called PZA. Here's what you need to know about the drugs. If you have active disease, you take 3 to 4 of them. If you have latent, you only take the INH, and you take them for 6 to 9 months, a very long time. And here's what you ought to know about them. They all cause, most of them cause a risk for liver damage. So if they cause a risk for liver damage, what should we do? Yeah, alcohol is a problem because it could make that happen faster. What else? What labs? So we need to do liver enzymes frequently, like probably every 6 months for them, I would bet. The other important one is rifampin. Rifampin causes orange discoloration of your body fluids. Urine, sweat, tears. You think it'd be important to tell somebody that? Otherwise, they're going to call your office in panic. Or they're going to make an appointment thinking they have a UTI. So it's really important we teach that. We always test on stuff like that. On Hep C, NRS, forever and ever, because it's weird. And if it happens, it looks like something that should make you stop the med, and you don't need to stop it. It's just what happens with this drug. And they keep taking it, and they just can't know it out. The OT already mentioned. Alright, the nurse recognizes the goals of teaching regarding transmission of TB have been met when the patient with TB, A, demonstrates correct use of the nebulizer, B, reports daily to the public health department, C, washes dishes and personal items after use, or D, covers the mouth and nose with D. So this simple little tricks in here, this is kind of how SC English questions are. You care about transmission, not treatment. So how do we keep other people from getting it? This is to distract you and think that it's passed through fecal contamination, that kind of stuff, and that's not true. Oh, and this, you don't go to the public health department, which is kind of a mean trick, actually. Plus, that doesn't keep you from passing it to other people. Probably. I don't know. Probably, though. I mean, you are a public health risk if you've chosen not to. I don't know how they would truly make that happen, but I guess they could, ordered-wise, yeah. Although, again, it's not highly contagious, but that is the problem. Especially, I'm sure they can make inmates do it, because that's one of the big places that passes through the roof. Okay, environmental lung diseases. I just want you to know in a very general sense about these diseases, okay? So these are the general things I want you to know. Usually these come from inhaling dust or chemicals, and it can either cause an acute disease, like Jamie has up there, or it could cause a chronic, damaging disease that could take years to develop, like asbestos. Before we knew what asbestos did to your lungs, people were being exposed to asbestos all the time, and they wouldn't get cancer for 20 years. So what's important is if you're in a high-risk profession or you're being exposed to chemicals or dust frequently for any reason, you need to pay attention to respiratory symptoms and seek treatment early, because it could happen at any time. So they need to know they have a risk for that. The other really important thing is this. Let's say they come to your clinic just for a physical, and you see they work at a concrete factory. Concrete factories have lots of dust, and it's very harmful to lungs. You need to tell them, now you need to ask them, do you wear protective equipment? And if they say, well, no, you need to say, well, does your boss provide protective equipment? Because if they don't, that's an OSHA violation, needs to be reported. But usually they do, because they know better, and the person's not wearing it. He's like, well, yeah, they do, but nobody wears it. Well, you need to tell them the risk, and the risk is this: if he gets something from his exposure, he won't be covered by workers' comp or any of that because he didn't wear the protective equipment. So it's important that we educate them. What common bad habit would make all of these things worse? than normal, but not that bad. Yeah, B we should mark off. I mean, could they choke? Could they have issues? But you can't add to that. That is a cough-productive thick-rim mucus. So probably an infection. All right, they're not high on my list. So now we're down to loud expiratory wheezes or respiratory rate at 38. This amazes me because, and you're not the only cause. It's even my med surg too. We've been fighting this for the last 2 weeks. Respiratory rate at 38. Do you think that is good? No. Even in a kid, we don't love that. 38 is super fast. The problem with super fast respiratory rates are you get tired. And then you won't breathe at all. You'll drop to 10 and then you'll be not breathing. 38 is very important. Anything in the 30s, you should be concerned. Loud expiratory wheezes, I mean, should we check them? Yeah, it could be a lot of things. So should they be checked? Yes. They're certainly up there, but that's more distinctly a bad thing than the loud expiratory wheezes. So those would need to be checked. This is going to be more important. All right, lung cancer. Shocker. Cigarette smoking, most important risk factor. Here, I'm going to sum up lung cancer for you. It's almost always slow growing. So most people are not diagnosed until it's late in the game. They don't have very many symptoms. In fact, it takes 10 years sometimes for a lesion to be big enough in the lung to see on x-ray. That's how slow growing this cancer is. And so we oftentimes don't have any symptoms, so we've got to work on prevention and early recognition. These also easily metastasize, which is not a good thing. Now this is type. You don't have to know the types. I'll tell it to you: non-small cell lung cancer and small cell lung cancer. You don't have to know those types though for me. Here's the signs and symptoms. It's typically asymptomatic until late in the disease process. However, please hear me. Persistent cough with sputum should be a reason to go to the doctor. If you're always coughing, you haven't had a respiratory illness, or it's not going away for months, you need to see a doctor, because that we might catch it earlier. So it's not that it has no symptoms at all, it's that there are very few symptoms, and if you have any, they're very vague. So it's hard to see, but it means if you have a lot of risk factors, you should pay attention to little things like a persistent cough. If you get to weight loss, nausea, vomiting, hoarseness, which can indicate the laryngeal nerve, you're going to be at the late stage of this. Sometimes this is just caught because people have a chest x-ray for a routine elective surgery. So sometimes there aren't any symptoms, but if you're at risk, you should be watching for little things. Diagnostic studies, a chest x-ray might show it. If it doesn't, and you come in with respiratory symptoms, and you're high risk for cancer, then they might do a CT to see something smaller than x-ray would show. Biopsy always has to be done to confirm cancer. You can't just say, yeah, that looks like cancer, and it's cancer. You've got to biopsy. With small cell lung cancer, it's always aggressive, it's always metastatic, so they don't actually stage small cell at all because it's always bad. Surgery, lobectomy or pneumonectomy. So I'll put this up next quarter too, but I'd like you to understand what's happening to these surgeries in a general sense. This is a wedge resection. They're just cutting out like a triangle wedge piece of lung with the mass in it. So it's just that little bit. This would be a segment resection, not a whole lobe, but part of the lobe. This is a lobectomy, an entire lobe of the lung. And this is a pneumonectomy. A pneumonectomy is the entire lung is removed. Are you going to hear breath sounds on that side? You guys laugh. People will document that there's breath sounds over there. You won't hear breath sounds. There's no lung to hear breath sounds. So you don't trust yourself when you first get out in practice. won't be anything there. Radiation, chemo, they do need to stop smoking. That is just making their disease progress faster and worse. So even if they smoked for 75 years, we already talked about, you will see changes in the next 2 to 3 weeks if you stop smoking, even if you smoked your entire life. And we got to explain that to patients. The big things that tend to happen with them is coughing up blood, which could make them very anemic, hemoptysis, dysphagia. They have difficulty swallowing. When that happens, what's our risk? Aspiration. A lot of times these people cannot take in enough calories to maintain weight because of the dysphagia, and they end up needing a feeding tube, and then they have risk. Hoarseness, chest pain, all of those things could indicate extent of disease, that the disease is invading nerves or vessels or other things. So that's why those things. Basically, with lung cancer, you need to talk about hospice because there's just not a lot we can do. Usually they're stage 4, the treatment's not very effective, and so hospice is usually where we're going to palliative care, pain management.
Is the pneumonectomy often?
We do see pneumonectomies quite a bit. I don't know in the grand scheme of things, but I've definitely seen several times we've had pneumonectomy. Kind of interesting. They'll put a chest tube in after pneumonectomy because they're just draining serous fluid that accumulates there, and then that space just isn't have anything there. Your chest wall is keeping it, your ribs are keeping the shape, and there's just nothing in it. Again, sorry I sent obstructive out so late, but it's so much better now than it was. I'm glad I took the time to fix it. Otherwise, I'd be whining about this one too. First time you make a PowerPoint, you just don't get it right. Yeah, there's copies up there for anybody else that needs them. Okay, the obstructive pulmonary disorders include asthma, COPD, which is emphysema and chronic bronchitis, cystic fibrosis, and bronchiectasis. Bronchiectasis we'll cover in one slide. We're going to spend all our time really on asthma and COPD. These are our most common chronic lung diseases. And what happens is, I can't see this real well, but we have bronchoconstriction, shortness of breath. I have no idea what that says. Mucus secretion. And here's emphysema, there's chronic bronchitis, there's asthma, and you see that a lot of their symptoms overlap. So there is a little bit different patho happening with each of these disorders. You want to understand the patho a little bit and understand, like asthma is reversible unless it's not controlled, and then you get permanent damage. COPD is not reversible. We can slow the progression, but it's not reversible. So there are some very key defining things between the three disorders, but there are a lot of things that overlap that seem alike. So we'll kind of talk about them in terms of patho. Asthma is more a reactive, we call it a reactive airway disease. Sometimes you'll see it abbreviated like this. Hyperreactive airway disease. Do you see that in a chart? They mean asthma. And it's inflammatory. So again, reversible in the early stages. It only affects airways. It doesn't affect your alveoli in terms of having any sort of damage at the alveolar level. And oftentimes, it is intermittent. You can have a lot of attacks, but it's an intermittent thing. Emphysema and chronic bronchitis both fall under COPD, and these are irreversible. Again, we can slow the progression a little bit. They are always going to have a limitation in airflow. So it's going to progressively get worse. So they start out with a limitation, and then it gets worse and worse. Emphysema affects the alveoli themselves, and chronic bronchitis affects your airways. again, these are kind of defining things. Now, cystic fibrosis is a genetic disorder. It gives airway obstruction because they have increased mucus production. It is not just an airway disease, though. It affects the pancreas, it affects the GI system, it affects a lot of things. And you'll cover it again in peds, but we used to never cover it in adults, but now people are living to their 30s. They used to only live to their 20s, and now they're almost living to their 40s on average. So we have to teach it in adults now. Where before, we just keep them at the peds hospital. They might be 22, 23, and they just keep them at the peds hospital because we can cystic fibrosis in the adults. Bronchiectasis, we'll talk about that. Alright, so asthma is what we're going to start with. Inflammatory disorder of the airways again. Let's talk about the risk factors, and then we'll talk about the patho effect from that. You can have varying levels of asthma, by the way. You could have mild or just intermittent. You could have persistent, mild, moderate, severe. So people have varying degrees, and people might have it really bad when they're young, and then when they're older, they don't have it, or vice versa, get it worse when they're older. So lots and lots of triggers and risk factors. There's a table in your book on this. I'm going to sum them up for you. Genetics. The genetics of asthma are too complex to even study. We think there's a genetic component of some sort to it, but it's multiple genes that may be involved. We see like kids that we call atopic, they have dermatitis and allergies and a variety of things. They end up with asthma, and that's all the complex thing. So it's not like we can say this gene causes it, so we can try to fix it like we do with CF, that kind of stuff. Immune response. This is a kind of a unusual and confusing thing, but I guess you just have to accept it. Here's what we know about the immune response. We think that children are not exposed enough to childhood diseases because we have so many vaccines, and we keep people so much healthier. We use antibacterial wipes and antibacterial soap, and we keep everything so safe and clean that the body is not able to learn how to mount a good immune response, and without those protective antibodies, we may be more prone to asthma. Isn't that weird? So not a lot we can do about that. Allergens, big, big problem. Roaches is a big one that you can be allergic to. Pets, fungi, mold, not everything that triggers it can we do anything about, but it's really important we find their triggers and try to fix it. Things like, sometimes we tell people you need to get rid of your carpet, you need wood floors. We definitely will tell people get rid of dogs and cats. I remember having asthma as a kid, and back then, Holly Hobby was a big deal. You guys probably don't even know who Holly Hobby is. But Holly Hobby, you had these beds with canopies over them, and they were so cute. Every little girl wanted one. If you had asthma, you can have that, because it's just a dust collector up there. Stuffed animals, they collect dust. There's lots of things like that we try to get rid of in kids' environments. Exercise. Exercise. If you have exercise asthma, you usually don't get asthma problems during the exercise, you get it after. If it's just exercise-induced asthma. And worse if you're in cold or dry air, which is all of Colorado. And so you get triggered easier. Air pollutants, lots to talk about this. Smoke, ozone, car exhaust. We have a huge rise in asthma in kids, so we think some of it has to do with that. Occupations, that could be beauticians. They're exposed to a lot of chemicals that could cause an irritant and then a reaction in the airway. Bakers, hospital workers, because of chemicals. Agriculture, lots of occupations that could trigger it. Respiratory infections, usually viral, trigger an asthma response. Although bacteria can do it too. Nose and sinus problems, sinusitis, rhinitis often triggers asthma. Drug and food additives. This isn't so much allergies, although we do have some food allergies that cause it, but things like dyes and sulfites in the food, and then aspirin, big one you could be allergic to, NSAIDs, a big one you could be allergic to, and then beta blockers, which we've talked about. You guys clearly got that. It's so funny, I've never had a class pick that. I'm like, alright, I gotta think about how to word that. It was overwhelmingly B, Erin. Overwhelming. Like 94% of the class missed that question. Not 94 had B, but 94 missed the question. I'm like, okay, I think I'll take more answers. Alright, GERD. GERD, we think, triggers bronchospasm. And you can aspirate, and then that can cause damage in the airway. So GERD is kind of controversial, but in kids, you'll cover this in peds. In kids, any kid that is wheezing, we will look for GERD first, and we'll try to treat GERD before we'll look for asthma. Extremes of emotion, crying, laughing, stress. Again, I have asthma. The worst trigger for me, laughing. And my family is so goofy. And they'll get me laughing, and then I start wheezing, like, thanks a lot. Now I need the inhaler. Laughing gets me. Obesity, just I think pressure and lack of ability to compensate. Alright, here's the path though. Most of this you understand, one part you usually don't. Airway inflammation that causes bronchoconstriction, which you know, and narrowing, hyperreactivity, so it kind of creates a cycle, and airway edema. All of this increases mucus production. So that's the part most people don't realize about asthma, is you don't just have the airway narrowing and the wheezing, you get increased mucus production. But be cautious knowing that, because we're not going to give you drugs to stop the mucus production or dry it up, because as soon as we fix the airway reactivity problem, the mucus production goes away. It's kind of a consequence, but they do cough up a lot of stuff because of the patho of it all. If you have chronic, you have frequent attacks, that's what leads to damage in the lungs and true structural changes. That's what can make it irreversible in nature, is when you have chronic problems that you don't take care of. So the other thing that happens is in an acute attack, the patient starts to hyperventilate and breathe fast because their airways are so narrow they can't get a lot in. That gets them a little hypoxic, and they start working harder and harder to breathe, and that leads to respiratory failure, fatigue. So if I'm huffing and puffing at home, so I'm having an asthma attack and I'm wheezing and I have this, so I know what to do, use my inhaler, I'm still huffing and puffing, maybe I carry on like this for 2 or 3 days, where I just use my inhaler a lot, I'm coughing and wheezing and all this. I finally go to the doctor in 3 days, and by that point, I've been doing this for 3 days, and I'm kind of tired, I'm breathing 30, 32, 34, 36 times a minute, working hard. I have a risk of just tiring out because I'm using all those accessory muscles. The use of accessory muscles is work of breathing, right? Increased work of breathing. So I get tired from all of that, and eventually my body just says I can't do it anymore. And so my respiratory rate will go from 36 to 10. That's not good. That doesn't mean you miraculously cured me because I walked in your ER. It means I'm exhausted and I will quit breathing. And you're going to need to intubate. So this can resolve by itself spontaneously or need treatment. That treatment could be at home. In fact, patients need to know what to do at home and at what point they go to the doctor, and you guys have to know that. You need to know at what point they need to seek some more help. Alright, here's the signs and symptoms. They're somewhat unpredictable. When we have episodes of wheezing, be sure you can recognize description of wheezing on the test, because they're not going to say the word wheezing necessarily. So how would you describe wheezing? asthmatic wheezes, like audibly, externally wheezes, externally, it's a new word I created. Externally wheezes, they don't all wheeze and they don't all cough. A lot of asthmatics kind of do one or the other. They're a wheezer where they cough, 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 and just never stop. And so when you listen by auscultation, you'll hear wheezes and squeaks, that kind of stuff. But you might not hear anything externally. Typically, they will report their symptoms are worse at night and in the early morning. That's one of the definer things. A lot of times, totally asymptomatic between attacks. That's also can be defining as you try to diagnose somebody. Prolonged expiration, so remember expiratory ratio is 1 to 2 normally. They'll have a prolonged expiration because they're trying to keep those alveoli open, trying to slow their breathing. I mentioned this, I think, last week. When I'm having an asthma attack, I don't want to breathe through my mouth because it triggers me. So I breathe through my nose and I prolong expiration, trying to keep from taking that breath in because it always triggers me to cough or wheeze. So you do it unconsciously. Wheezing itself is a completely unreliable sign of how bad the attack is. So it's important to understand this. You can't wheeze if you're not moving air. So here's what happens, and we do asthmatics all the time in peds. It's one of those things I'm really good at because that's what we do in peds. When you listen to an asthmatic, you can see their chest going up and down. So you can see they're breathing 30 times a minute, and you go to listen, and you hear nothing. Nothing. So you're like, okay, I can see they're breathing. So you tap your stethoscope, like, do I have the bell turned the wrong way? So you'll see people always are tapping it because they think they've got to turn, and you turn it, you tap it again, you're like, oh no, it's right. You put it on there and you listen, you don't hear any breath sounds. None. And you can see their chest rising. It's because they're so tight that they're not moving air through. So their chest is rising, but air's really not getting through, because they're so tight. So what you do is you give them a bronchodilator. When you give them the bronchodilator, that should open things up. When you go listen after the bronchodilator, guess how they sound? What?
Normal.
They don't sound normal. Not just fast, they sound horrid. Horrid. So before you heard nothing, or maybe you just heard a few squeaks, and once you give them the bronchodilator, they will sound terrible. Like they'll sound junky and crackly and wheezes everywhere and coarse, like just this real noisy breathing. They're actually better because now they are moving air. When I listened before, I really didn't hear any breath sounds. Like I was lucky to hear a few squeaks, though I could see their lungs or their chest was moving. When you get them open a little, then they sound horrible. That actually means they're better. And then you give them another breathing treatment, and now you're listening to sound better. So after you can hear stuff moving, then you're listening for clarity and breath sounds everywhere and no wheezes. But the first time you listen, you can hear nothing. Anxiety, have you ever had difficulty breathing? You get a little anxious. And then what's that do? That makes you hyperventilate. You were already probably hyperventilating because you couldn't breathe. So now you're anxious and you hyperventilate more, and it just creates a vicious, terrible cycle. So telling an asthmatic to slow down their breathing, not going to do any good. How can I get an asthmatic to slow their breathing down?
Breathe with them.
Yeah, that's the secret. Is you say, okay, we got to calm down. I know you're anxious, but look, you're here. We've got oxygen on you. We're giving you medicine. Let's try to calm down. Breathe with me. In, out. In, out. That gets them focused on your face, and a lot of times you can calm them down because once you start that cycle, you get panicked. You feel like you can't catch your breath at all, and you get panicked, and that makes things worse. So if you can get them to focus and breathe with you, you'll get a much better response. All right, signs of distress. So I added this slide because we covered this in detail in MedSurg 2, but you need it before MedSurg 2. So when someone's unable to speak in complete sentences, what that is? In kids, we call it retractions. In adults, use of accessory muscles, the ribs caving in, the sternum, clavicles. This is oftentimes a little more significant than the respiratory rate itself, but we do care about respiratory rate. So anything over 30, we're concerned. Heart rate over 120, we're concerned. Why do you think your heart rate's up? Yeah, they're anxious, they're hyperventilating, having trouble breathing, so the heart's going to come up as the body releases catecholamines and it's fight or flight response. So the heart rate goes up, respiratory rate, blood pressure, everything goes up. So we're not as freaked out about that stuff when you're in the throes of an asthma attack because it's kind of to be expected. But the higher your respiratory rate goes, the more in distress you are. Shortness of breath at rest. So if you just ran around the block, you're going to be short of breath. If you're sitting right here looking at me and you're working to breathe, that's concerning. Tripod, don't confuse this. Do think of anybody that has to be in tripod position to breathe easy, which you can ask them, are you sitting like that because it's too hard to breathe when you lay back? And if they say yes, that's work of breathing. Now, people with chronic COPD, they tripod because they're always having work of breathing. It's not as concerning with them because that's what they do every day, but it's still concerning. You do that to allow gravity to help you, not have to lift your chest. It just decreases your work some. So that tripod position is concerning. Peak flow, we're going to talk about that in just a few slides. Peak flow is very important for monitoring asthma. And so you do need to understand how to do it and what it means. We'll talk about the percents on another slide, so don't worry about this one. By the way, when you're in the middle of an asthma attack, you oftentimes can't get a peak flow. You're too tight to be able to give us peak flow at all. So it's really better used as a predictor beforehand. So we would want to ask, what has your peak flow been doing for the last couple of days? And if they say, what's a peak flow, you know the problem, because they should be using a peak flow. So we'll talk about that in a minute. Diaphoresis, sweating, drowsy, confused, agitated. What's that indicate? Hypoxia. Silent chest, that's what I mentioned before, where you go to listen, you can see their chest rising, but you hear nothing. That's silent chest, that's not a good thing. Bradycardia, so look up here. These are ominous things. When your respiratory rate drops, your heart rate drops, we don't hear anything, that's a big concern. So the high respiratory rate is a big concern, but a low one is a big concern. Because if you're in distress, you should not be breathing slowly. You should be working hard as you can to breathe. So you're going to breathe fast. If you start breathing slowly, that's not a sign you're better. It's a sign you're going to quit breathing, and we don't want that to happen. Same thing with bradycardia. If your heart rate's been racing at 120 and it drops to the 60s, you're tired. You're gonna respiratory arrest and then probably cardiac arrest because you're just working too hard. Let's take a break for right there.
Whatever, there's 9.
I feel it.